So I want to start with J. Marion Sims's documentation of his attempt at artificial insemination using a syringe and cannula in his book Clinical Notes on Uterine Surgery from 1866, as it had a distinct technological and practice-based impact on U.S. and European gynecology. Sims based his gynecological research on enslaved women in the slave hospital in Montgomery, Alabama, in the U.S. from 1845 to 1849, and on free women at the Women's Hospital in New York City, starting in 1855. As the historian Deirdre Cooper Owens wrote in her book Medical Bondage, quote, Sims depended on enslaved Black women's bodies to discover cures for vesicovaginal fistulae and to perfect surgical instruments such as the duck-billed speculum, achievements that were responsible for his global status as a pioneering gynecological surgeon. And we could talk about his experiments on enslaved women in the Q&A later, but thus the infamy in addition to the fame. But the artificial insemination experiment that he outlined in Clinical Notes on Uterine Surgery was notable not for its success. As mentioned earlier, a few minutes ago, only 1 out of 55 patients achieved pregnancy, and she miscarried after 4 months. But for the description of the syringe and cannula that Sims used to assist with that pregnancy. Though 2 images of the tools that he used appear next to his description, visually and reinforcing his point that the tools themselves were simple and replicable by readers. And you can see in this photograph of the syringe that this was quite a simple tool. But the technological history of artificial insemination remained static for decades after Sims published his description of it in 1866. Those are circumstances in which it was used either by physicians or at home, and the sperm used in the process from a husband, an anonymous donor, a known donor, or a mixture of husband and donor varied significantly. The tools, a syringe, a cannula, and a small canister or jar for the semen, stayed the same. The semen had to be fresh, at least at the establishment of sperm banks in the 1950s allowed for sperm to be frozen ahead of time. But until the timing of ovulation was confirmed in the late 1920s and early 1930s, and then publicized in the mid-1930s, calculation of the best time in the menstrual cycle for artificial insemination was guesswork. As the use of AI was often kept secret due to embarrassment on the married couple's part, and it was usually only married heterosexual couples who engaged in AI, the illegality of the treatment in some countries, or its being forbidden by the Roman Catholic Church in 1897 onward, reports of children conceived with AI were publicly received with mixtures of curiosity, anger, or even disgust at medical interference with the natural process of insemination via sexual intercourse. In the medical realm, however, technology-assisted artificial insemination with husband or donor sperm was old news for U.S. and European gynecologists by the 1910s, so 2 or 3 generations after Sims. For example, in the U.S., Dr. Elijah Mosher wrote an article in 1912 advocating artificial insemination as both, quote, proper and peculiarly adapted to women in medicine. And Dr. Robert Latote Dickinson used his inaugural speech as the newly elected president of the American Gynecological Society in 1920 to promote research on what he called artificial impregnation. 1920s, Germany and Switzerland, AI for both humans and animals was a popular topic of discussion, though few gynecologists would admit to using it. However, if a couple wanted a physician's assistance, they could arrange postcoital artificial insemination, a process that the Dutch physician Dr. Theodore H. van de Velde described in his 1929 book, Fertility and Sterility in Marriage. First, the couple had intercourse while the doctor waited nearby, and the visuals of this are really, really something in your mind. After ejaculation, they would summon the doctor, who would immediately scoop out the ejaculate into a spray device. The doctor would then perform AI, and this is a quote from Van de Velde. The portio of the vagina must then be grasped by a tenaculum forceps, which you see in front of you. The cannula of the spray passed up through the cervix until its extremity is at least above the interior os, and then a little of the seminal fluid should be slowly injected into the uterus. Then, and the quote continues, the cannula should be left motionless for a few minutes, and then very slowly retracted, the portio released, the speculum removed, and the woman put into bed. Then the woman put into the horizontal position with as little movement as possible and kept quiet in bed for the day. Alternatively, the couple could have intercourse at home with a condom, then bring the ejaculate-filled condom to the doctor's office where AI would then take place, which provides you another interesting visual of a couple with a little rubber condom, hoping that nothing spills out on their way to the doctor's office. But beginning in the early 1930s, after Kaiusaku Ogino in Japan and Hermann Canals in Austria independently confirmed and publicized the timing of ovulation, physicians started to time AI treatments to coincide with ovulation to increase their chances of success. If the fertility problem was with the man's sperm, physicians in the United States, in the UK, Mexico, Israel, Taiwan, and probably other countries used donor sperm or mixed donor sperm with the husband's sperm to make any potential child's real parentage unknown. The mixed sperm method also preserved the husband's sense of masculinity in the face of male factor infertility. The thinking behind this practice was as follows. The fact that a child could be his, even if it was almost certainly was not, was less likely to challenge existing emotional bonds between him and his wife, him and his future child or children, or his own sense of virility. Fast forward to the present, and artificial insemination is still ongoing. Home-based insemination persists, especially in countries where access to assisted reproductive technologies is restricted or illegal for some identity groups, usually gay, trans, non-binary, and lesbian individuals. They may find assistance in printed or internet guides to doing so, which originate in the feminist women's health movements of the 1970s. Lesbian insemination guidebooks have been in print since 1979, and syringes, cannulas, cervical caps, diaphragms, eyedroppers, and jars are available to anyone who purchases them from a medical supply store, as the basic techniques of AI have changed little since the mid-19th century. And so what you can see in front of you is another duplicate image of the Sims syringe from 1866, and also just a at-home insemination set from the US retailer Target, which is basically identical except the direction of the syringe is reversed. Almost absolutely identical. Now, the second area of technology that I would like to highlight is diagnostics, and both for men and for women. And infertility diagnostics in men began with, guess who? J. Marion Sims, who outlined his process for examining postcoital sperm under a microscope to look for abnormalities in an article in the British Medical Journal in 1868, drawing attention to the fact that infertility was not only a female problem, that spermatic health and more broadly men's health could also play a role. Another American physician, Max Huner, a couple generations later, advanced Sims's microexamination practices and designed a test to determine postcoital sperm motility microscopically. The correlation of what became known as the Sims-Huner test or postcoital test with the chance of pregnancy has been debated amongst gynecologists ever since Huner published his method in 1913. For women, fertility diagnostics historically focused on the fallopian tubes. The blockages in the fallopian tubes were a common source of fertility problems. Those surgeons could attempt to remove these blockages via a high-risk procedure called a salpingostomy, which was first attempted in 1889. Women became pregnant after this surgery at a rate of roughly 7%, reported by American physicians and 8 to 10% reported by UK physicians. Father and son physicians William L. Estes Sr. and William L. Estes Jr., both practicing in Bethlehem, Pennsylvania in the U.S., developed another surgical procedure that connected the ovaries directly to the uterus on one or both sides, bypassing the fallopian tubes. Then ovulation could take place directly in the uterus. The Estes operation never became popular among gynecological surgeons. In a 1910 article, Estes Sr. stated that out of 40 operations, he knew of only 2 pregnancies and 1 live birth. Estes Jr.'s investigations into its historical use revealed 2 live births after 27 operations from 1895 to 1924. And his decision not to treat anyone over the age of 30 indicated his belief that it was best suited for younger patients. And that we'll come back to that age issue again. And moving on to a more widely used technique. In the 1910s, 2 European gynecologists turned their attention from surgical techniques like this to bypass fertility problems to diagnostic tools, and in doing so made major advances in those diagnostic techniques. Doctors Isidore C. Rubin in Vienna and G. Lelourier in Paris designed the non-surgical technique of insufflation contemporaneously. Rubin began his experiments with injecting a colloidal silver solution called collar gall into the wombs of deceased mammals and women in 1914. Of course, you do not want to inject colloidal silver into anyone living. But World War I interrupted both of their research programs, and Rubin escaped to New York City. And the Laurier kind of falls off the historical map. In 1919, Rubin revived his experiments on living women with a different set of substances. He drove oxygen and carbonic acid gas into the tubal duct with a different set of into the tubal duct from the uterus with a machine called a tubal insufflator combined with a manometer, an instrument that measures the pressure of gases or vapors, which showed and regulated the necessary degree of pressure. Insufflation pushed gas into a woman's uterus to inflate it, which would then show the amount of blockage in the fallopian tubes. The amount of pressure that indicated clear fallopian tubes varied according to how many children a woman had already birthed or not birthed, and the pressure itself could also remove some tissue blockages by force. The pressure measurement was expressed on a graphing instrument called a kymograph, which recorded the changes in pelvic pressure that the manometer measured. And in this picture, you can see the black tube that goes behind the machine would be placed into the vaginal canal. You can see the pressure gauge up at the top right-hand corner. And then on the left, you can see the kymograph. It does not have a stylus, or the stylus is at the bottom. And the stylus would record changes in pressure as the gas was released. This is not a fun process. But in 1925, Rubin presented his machines and technique at a meeting of the Section of Obstetrics and Gynecology, or Royal Society of Medicine in the UK. By the end of the decade, Dr. Sidney Forsythe, a surgeon at the Soho Hospital for Women in London, developed an analogous process using an oil-based solution, like Lipidol, an oil containing 10% iodine, and X-rays. The Lipidol was injected into the uterus with a rubber bulb attached to a Tycos brand manometer with a fluorescent face. The fluorescence was necessary because the tests were administered in a dark room with the gynecologist and the X-ray technician to see fluid move through the X-rays properly. After the diagnostic session, the Lipidol could remain in the pelvic cavity up to 6 months, causing irritation and, again, pain. Forsythe's method was called a salpingogram or hysterosalpingogram and identified the location of the blockage more precisely than insufflation. The establishment of insufflation and the salpingogram as techniques and the creation of the machines used to execute them had a profound effect on fertility diagnostics. As Theodore Van de Velde put it, This is a quote. By means of insufflation and salpingograms, it has become possible to ascertain and exactly locate such causes of feminine sterility as occlusions of the tubes and adhesions of tubes to ovaries, without a laparotomy or without opening the abdomen surgically. So even though both methods could potentially cause fatal harm to women via embolism or infection, and despite the rate of false negatives, up to 37% in the case of insufflation, their use became standard elements of fertility medicine for the next half century. However, advanced surgically based diagnostic methods became, though they were not infertility cures. Gynecologists from the 1910s through the 1950s focused on blockages in the fallopian tubes and paid less attention to other factors involved in infertility, such as ovulatory abnormalities, cervical factors, and sperm deficiency. Why? There was not a lot of money in developing technologies for these kinds of problems and not a lot of interest. Obstetrics and gynecology were not as well paid as other fields, and doctors in the field did not have as much freedom to experiment and still be able to financially support themselves. So now I'd like to move on to the third area of fertility technology. Under discussion today, let's move to IVF. In the 1960s, a small number of obstetricians, gynecologists, and embryologists started pursuing treatments that would eventually revolutionize care for those desiring pregnancy: in vitro or in glass fertilization. Experiments with IVF as a technique and the technologies necessary to make it possible began on animals as early as the 1870s, but not until the 1940s in humans. Dr. John Rock in Massachusetts spearheaded the human-oriented effort, but abandoned it in 1950 after 9 years of trying, realizing how long it would take. And eventually he turned to the other side of the fertility spectrum and worked on the creation of the birth control pill. So the trio that would become famous for IVF research, Patrick Steptoe, who's a gynecologist, you see him in the dark rim glasses in the photo, Robert Edwards, seated next to him, and Jean Purdy, who's a laboratory assistant. The three of them began experimenting with various forms of growth media, the timing of implantation, embryo and zygote growth periods, and implementation techniques in the mid-1960s at Bourne Hall near Cambridge. The next steps were to harvest sperm, as physicians had done for AI since the 1860s, but then the tricky part was fertilizing the egg artificially. In order to streamline this process, Steptoe used laparoscopy, a non-invasive surgical technique that he first learned in 1958 from the French physician Raoul Palmer, to gather sperm immediately from the vagina after intercourse. The addition of a light source on the end of the laparoscope for better visibility was critical to IVF's eventual success. Steptoe and his Australian counterpart, John Leeton, also used other existing surgical and laboratory tools to make egg retrieval and embryo transfer possible. These included a micromanipulator, an instrument for manipulating microneedles and micropipettes invented for cell surgery in 1912, and a microscope with a motion picture camera attached to observe the dissection of chromosomes. One further necessary technological step was the creation of a medium or culture fluid in which embryos could grow outside the uterus. In 1968, one of their research associates, Barry Bavister, found a usable medium based on one used for hamster IVF. So we see animals kind of around the edges and being made critical to human IVF. So after the technological components were in place, the Cambridge team used IVF on Leslie Brown, who received IVF treatments successfully using an egg generated from her natural cycle, although she had to go through several cycles before one was implanted successfully. An 8-cell embryo was transferred into her uterus in November of 1977, and in July of 1978, that procedure resulted in the birth via planned cesarean section of her daughter Louise Joy Brown. Louise's birth was worldwide news and widely seen as a significant marker in reproductive technological history. The potential of IVF quickly became obvious. It could bypass fertility problems such as damaged or blocked fallopian tubes, endometriosis, and poor sperm-mucus interaction, and could help patients with these conditions achieve pregnancy. The next major innovation after IVF was intracytoplasmic sperm injection, or ICSI. After IVF was standardized, research groups around the world tried to find ways to help patients with low sperm count, known as azoospermia, and a team at the University Hospital of the Free University Brussels in Belgium developed a technique called subzonal insemination, which they nicknamed SUSI, on mice, which was, so quote, a micromanipulation technique involving the insertion of a few spermatozoa between the zona pellucida, or the outer layer of the ovum, and the membrane of the oocyte. The SUSI procedure was delicate, and occasionally one of the sperm entered into the cytoplasm of the oocyte. The researchers called this event failed SUSI, but it was not a failure at all. After the sperm entered the cytoplasm, in the words of one of ICSI's founders, we observed normal fertilization as well as embryo development and called this procedure intracytoplasmic sperm injection. The first baby was born from this procedure on January 14th, 1992, and ICSI proved to be a consistent treatment for the alleviation of infertility due to severe semen abnormalities. The ICSI process allows men previously considered infertile because of low sperm count or impaired motility to forego the use of a donor. Moving forward in time, as the outgrowth of IVF-adjacent technologies, which are also known as add-ons or adjuncts, happens quickly, it is useful to take stock of the core process that has become more or less standardized in industrialized countries, or at least countries with significant reproductive technology infrastructure as of the mid-2010s. So I won't read all this to you. This is based on a list created by Sarah Franklin. And so there are at least 11 or 12 steps, and some of these are condensed here. And you have to have investigations, choose a program, basic workup, do first cycle, induce the ovulation, aspirate the eggs, get the sperm sample, prepare the ICSI, conduct the ICSI, and patient still must lie still. As you saw, that's a perennial need in these treatments. Do pregnancy testing, prenatal monitoring, and then hopefully get to the birth phase. This is not for the faint of heart. And so the process in 2015 or so in the US, UK, and these other countries with advanced technological infrastructure may also include what pre-implantation genetic screening, known as PGS or PGTA, somewhere between steps 5 and 6. And since the mid-2010s, even more of these optional add-ons are available, which I'll discuss in a few minutes. So you might be wondering, how successful is all of this? Really, in a way, depends on who you ask, how they define success, how they keep statistics, whether those statistics are publicly available through the clinic itself, or through a government agency, or a professional accrediting organization. No, not all countries or professional bodies require fertility clinics to submit their statistics or to publish them, nor do they all conduct audits of clinics. And data submission and analytic parameters vary from country to country and from accrediting organization to accrediting organization. But most potential clients ultimately are interested in, again, what's called the take-home baby rate, or the percentage of clients who take home either a single live child or multiples at the end of a treatment. Those statistics help individuals and couples determine if a specific clinic is right for them. In a review of results from Australia and New Zealand in 2012, the live delivery rate per IVF cycle for all women was around 14 to 17%. In the 2014 report from the National Center for chronic disease prevention and health promotion, 40.5% of all U.S. women under 35 years old had a live birth after treatment, but only 1.8% of women over 44 did. The UK's Human Fertilization and Embryology Authority publishes an annual statistical report compiled from clinics countrywide. The 2021 report on 2019 data stated a live birth rate of 32% per embryo transfer for patients under 35 years old and below 5% for patients who were 43 years old or older. At the same time, the percentage of patients seeking IVF treatment at the age of 40 or older increased from 10% in 1991, 20%, 21%. Thus, the people who seek fertility treatment the most are unfortunately least likely to conceive and bear a child using IVF. They may end up exploring other options if that treatment does not work for them. Now, I'd like to turn to the present state of fertility technology in this last section and offer a few speculations on its future and aim to point out that the future of fertility technology, as I hinted at in the first section, is not only in assisted reproductive technologies. At different points along the path towards pregnancy attract different kinds of innovators with creative approaches to fertility problems. There's no shortage of people who are interested in developing reproductive technologies and improving the success of existing ones. So I will address 5 of the many, many, many possible topics: sperm health, home-based AI and ovulation tracking, time-lapse embryo imaging, uterine donation, and in vitro gametogenesis. Well, the first point of future technological interest is the health of sperm. As mentioned earlier, the precise correlation of the Sims-Hüner test or the postcoital test with the chance of pregnancy has remained unclear for over a century, but healthy sperm are a clear necessity for successful fertilization. Low sperm count, low motility, irregular morphology, enlarged veins in the scrotum, damaged sperm ducts, hormonal deficiencies, testicular failure, and sperm antibodies or proteins that damage and kill sperm are all sources of infertility. Sperm health is difficult to treat, and some workarounds for those with at least some healthy sperm include what's called testicular sperm attraction, or TESE, and testicular sperm aspiration, TESA, which both involve special high-powered needles and delicate microsurgical instruments to take sperm directly from the testicles. Physicians can also do testicular mapping, a process of fine needle aspiration used to see what areas of the testes, if any, are producing sperm. Semen can also be manipulated to improve the likelihood of pregnancy and become what is now known as technosemen, or semen that has undergone laboratory manipulation to be suited especially for ICSI and IVF. Matthew Schmidt and Lisa Jean Moore define it as, quote, the new and improved bodily product that semen banks advertise to clients. These manipulation methods include the swim-up method, which means centrifuging the semen sample, removing the seminal fluid, and placing the remaining sperm pellet in an artificial insemination medium. After an hour, the most motile and active semen, which swim to the top of the solution, are retained. Another method is Percol washing, which involves layering the semen with a cleansing solution and centrifuging it for half an hour. Washed technosemen is thus perceivable as healthier and more potent than natural unmanipulated semen, and made more appealing to would-be pregnant persons seeking to buy semen from a sperm bank. These methods rid the semen of sperm that are of lower quality, though they cannot fix a sperm sample's existing problems. These kinds of techniques for sperm manipulation and sperm health will continue to be an important area of fertility research and should draw more attention. A second point of technological interest is actually look backward. So as mentioned before, technologies and methods with historical longevity, such as home-based insemination and ovulation timing or fertility calendars, will continue to coexist alongside advances in high technology methods. Home-based artificial insemination persists in countries where access to assisted reproductive technologies are restricted or illegal for some identity identity groups. And some individuals or couples end up making up their own technological practices that are partially technologically advanced and partially not. What Laura Mamo calls hybrid technology practices, borrowing from both high and low tech methods, or perhaps taking Clomid, which is an ovarian stimulant, but trying Clomid with IVF, with artificial insemination rather than IVF, to avoid the painful process of egg retrieval. And looking at this image of a fertility app on a smartwatch, ovulation tracking technologies have been updated in the 21st century through the development of smartphone apps and smart jewelry. As of 2019, there were 200 fertility tracking apps available for Apple or iOS smartphones. Menstrual tracking and fertility management apps are part of a much larger shift in the use of smartphones and watches to track personal health and wellness goals. I'm sure everyone's cell phone in the audience tracks your steps and your heart rate and your calories burned, even without you knowing it. For fertility apps, these are based on a person's basal body temperature, taking your temperature at the beginning of the day, right when you wake up, and the timing of ovulation. And again, these are methods based on the Augean-Knauss findings of the late 1920s and early 1930s. They correlate someone's input on basal body temperature with the Augean-Knauss calendar. And sometimes they use a mucus measurement as well, a cervical mucus measurement, to determine whether the watch wearer or app user is fertile or not. So this body monitoring technology, smart jewelry, serves a similar function as a tracking app on your phone. So these methods are not physically invasive, but they do put the burden of tracking fertile and non-fertile times squarely on the person in the relationship who can become pregnant. It is up to them to do the tracking. And they may not be physically invasive, but they also may take your data, remanipulate it, and use it to assist with the accuracy of an algorithm for other users of the app. So you don't always know where your data is going, where it's stored, and for how long. And third, moving on to the far end of the innovation spectrum, I want to next address time-lapse imaging. Time-lapse imaging of embryos from fertilization to 3 days afterward for double embryo transfer to 5 days afterward for single embryo transfer is designed to help embryologists choose the healthiest possible embryo for implantation. Time-lapse imaging technologies, as Lucy Van de Ville observes, they allow for continuous observation by taking photographs every 5 to 20 minutes while the embryos remain in the incubator. By matching the videos with growth patterns of embryos that developed into healthy fetuses, the time-lapse system suggests which embryos are most likely to grow into a baby, end quote. The time-lapse systems film the developing embryos and quantify the visual information onto a grid, like you see here. And then clinicians must have specialized training and algorithmic analysis to predict each one's likelihood of turning into a blastocyst. These systems, called EmbryoScope, manufactured by Vitrolife, and EVA, EEVA, short for Early Embryo Viability Assessment machine manufactured by Merck, depend on past selections to predict future embryo viability. In a May 2019 survey of fertility clinic websites in the UK, time-lapse imaging costs an average of £478 as a standalone treatment and an average of £4,020 as part of a treatment package. The systems cost clinics £75,000 to £80,000 each. And this process not only changes how laboratory techniques and embryologists see and choose embryos for implantation, they also change how a prospective parent or parents see their embryos. As Catherine Walby writes, quote, Ranking means that the woman or couple has a quantified sense of the blastocyst's potential for development. One more step further along the road of technical difficulty is IVF in persons with transplanted uteruses or uteri. And I understand in the UK, the first successful transplanted uterus just occurred. The first IVF procedure in a transplanted uterus from a live donor that resulted in a live birth happened in Gothenburg, Sweden in 2014. And the first live birth via IVF and a uterine transplant in the US occurred in 2017. And this transplant and IVF procedure has resulted in 70 uterine transfers with 14 live births worldwide as of June 2021. Uterine transplants have become a focus of reproductive medical attention in the last 2 decades because uterine transplantation is the only known treatment for women suffering from uterus factor infertility. And thus, the immediate purpose of the procedure is to restore fertility to patients with an abnormal, damaged, or absent uterus. If the transplant is successful, the donated uterus is then removed after a certain period of time and a certain number of successful IVF pregnancies, a number that the patient would determine. One of the trickiest parts for the potential gestating parent is how to find a transplantable uterus, as there is no registry, and prospective transplant recipients must secure their own donor, and these donors can be alive or on life support and before they're deceased. But interviews with 10 uterus seekers, I don't know of a better term for it, but uterus seekers in Sweden a few years ago described how they reached out to their mothers as well as older sisters or aunts, raising the possibility that they could gestate a child using the same uterus in which they themselves were gestated. The emotional intricacy of asking and possibly receiving an organ donation in this situation is obvious. But uterine transplants paired with IVF make pregnancy a possibility for transgender women or cisgender men as well. The availability of uterine transplants, along with pregnancies in transgender and non-binary individuals, alters traditional categories of parenthood in a male-female gender binary. IVF and uterine transplants likewise sparks the possibility of gestating pregnancies outside the human body completely in artificial wombs called ectogenesis. And research is underway in Sweden by the same team that facilitated the first uterine transplant to create this viable bioengineered uterus, including artificial amniotic fluid and an artificial endometrium. A bioengineered uterus could also be used for, say, part of pregnancy. For example, the gestation could begin in a human womb, but if the woman or pregnant person got an illness or couldn't carry the pregnancy further, the fetus could be transferred to an artificial one and finish gestating there. And a successful human ectogenesis, whether wholly or partially gestated in an artificial uterus, could open up a new world of possibilities of reproduction. Finally, farther still in the future is in vitro gametogenesis, or IVG, the creation of gametes using pluripotent stem cells, or cells that can differentiate into many cell types. If a patient cannot provide gametes for an assisted reproductive treatment, IVG could create gametes from their skin cells. This is a quote. Artificial gametes raise one of the most dramatic possibilities that 2 men, or maybe also 2 women, could create a baby that is genetically related to both of them in the same way as men and women. Artificial gametes widen procreative possibilities for those unable to reproduce via traditional methods of sexual reproduction. As a result, a couple of any gender could provide all the gametes needed to produce an embryo that is genetically related to both of them, specifically expanding the possibilities of couples across genders to reproduce together. But don't hold your breath, that development is decades away. And so this talk, I'm focusing on the technologies themselves, not as much on their implications or their possibilities for use via surrogates or others. So to move to some final thoughts, what does the development and use of these technologies mean for human society? I find 5 points. The first is international family making, in that the political and legal status of fertility technology in different countries shows that inequalities in national economies, infrastructures, and gendered power perpetuate inequalities in access to and use of fertility technology. So people seeking to found a family may have access to eggs or not sperm, or sperm but not eggs, or we didn't talk to them about race too much, but someone wants an egg from a person of particular ethnic heritage to mix with sperm with a different ethnic heritage, and those two elements have to be transported to yet a third location for implementation somewhere else. And laws and regulations, both within countries and between countries, not to mention the technological infrastructures of storage and transport, make family making with these processes an international event. A second point is the growth of fertility as a for-profit industry, because as we know, a lot of high-powered companies and large universities like my own at Columbia University offer one or two cycles often of IVF to their employees, or they offer it to assist with the cost of egg freezing covered by health insurance. And these decisions or these options may lead people to decide on freezing eggs or freezing embryos when it is not as much in their interest as it is in the interest of their employers. And if they're buying a package, they may end up buying more services than they actually need. The creation of these fertility packages and the development of industry around fertility also leads companies to develop more and more of these add-ons to drive the desire for extra services and that people may not even need. And interestingly, IVF and AI can serve dual roles in IVF and artificial insemination can play opposite roles in the formation of gender ideals. First, they can uphold tradition. The use of fertility technology in a heterosexual marriage can uphold binary gender norms and strengthen connections between motherhood and womanhood. Specifically, the idea that gestating and giving a birth to a child makes one a genuine woman and a genuine mother. And the historical and contemporary precepts of Roman Catholicism, Judaism, and Sunni and Shia Islam all reinforce these connections to one degree or another. But on the other hand, AI and IVF can also queer reproduction. They may make conception, gestation, and birth possible for individuals who intentionally use it to queer dualistic notions of gender and reproduction, and allow people who are transgender and non-binary or a gender of their own thinking possible. And pregnancy across and beyond genders is a new possibility. And the fourth point is that technologies for fertility diagnosis and treatment have really tipped more towards the treatment side of things and not as much towards diagnostics. And salpingograms and insufflation machines could and still do identify blockages in the fallopian tubes that impede the travel of the sperm to an egg. But of course, those kinds of blockages are only one kind of fertility issue. And so since manifesting a pregnancy from conception to live birth is a process that can still resist the most sophisticated diagnostic and treatment efforts available, people need more diagnostic technologies so they have a better idea of what the future holds for them in terms of their fertility. Finally, reproductive technologies change what it means to be a parent. As Emil Algrani puts it in Regulating Assisted Reproductive Technologies, reproductive technologies are increasingly allowing us to separate genetic, gestational, and social parenthood. And that's a quote. So a child could potentially have genetic parents of a donor sperm or donor egg. They could have a gestational parent or like a surrogate parent, and also the parents who actually take on the role of raising them after birth. So ideas of parenthood and family via these technologies is genuinely in flux. So I want to conclude with a final thought that this very brief history of fertility technologies can only hint at the vastly complex ways that the desire for children affects the lives of individuals, couples, communities, and nations. The technologies that make pregnancy possible for some people are a source of disappointment, pain, and struggle for others. They're a means of giving certain embryos a chance to develop as persons in the world, but also a means of keeping other embryos and potential persons out of the world. Fertility technologies are much more than a way to address reproductive health problems or simply a medical procedure to cure a specific condition. They are, and this is a quote, a tool through which people create people. And how they will develop next and what kinds of human life will emerge as a result of using them remains to be seen. And with that, I will thank you, show you a picture of my book, which is also right here. And I will be happy to answer your questions and have a conversation.